Good morning and welcome, everyone. We'll let folks get settled in and we will be starting momentarily. Thank you all for joining us today. All right, again, and welcome. Thank you all for joining us for Take 10, Transforming Care for Women with Substance Use Disorders and Their Families. This is session 2, focusing on SUDs in women, history, use, and treatment with your presenter, Ashley Ryan. Today's training does take place from 10 a.m. to 2 p.m. Central Time. This is a 2-hour session. The Great Lakes ATTC and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this training are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you all. If you are having any technical issues, please individually message me, Alyssa Koala, and I'd be happy to assist you. Any questions for the speaker, please put them in the Q&A section of your toolbar. Sometimes the chat can get a little crowded, so any questions, please put those in the Q&A section of your toolbar. The recording and PowerPoint will be made available on our website by the end of the week. If captions or the live transcript would be helpful, please locate that option using your Zoom toolbar. At the end of today's presentation, you will be redirected to a very short survey. And certificates with 2 NADAC CEs will be sent out via email to all who attend today's session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube channel, or our Spotify channel. And I'm excited to hand this over to your presenter, Ashley Ryan.
All right, thanks so much, Alyssa. Appreciate it. Hi, everyone. I am Ashley Ryan. I am thrilled to be here today to present the second part of this two-part training. Last week, we covered the history of women and SUD treatment in 30 minutes. That was a quick session. Today, we will have a longer session of 2 hours on women's substance use and treatment. So we'll be from 10 a.m. to noon Central Time and 11 a.m. to 1 p.m. Eastern Time. Hold on one second. My background is mostly in healthcare policy, compliance, and practice management. I currently have my own consulting firm, Ashley Ryan Consulting, which supports behavioral health agencies with project management, accreditation, and program evaluation. I have some clinical experience in outpatient and residential settings for men and women. I finished my Master's of Public Administration in 2022. I compiled much of this material for this presentation in my main master's research project, which revolved around women's treatment and trauma from a public administration lens. My primary connection to the disease is as an adult child. I am located in Cleveland, Ohio, and was director of a women's substance use disorder outpatient treatment facility. Our program provided extensive wraparound support for women, including childcare, transportation, trauma therapy, and case management. Please feel free to ask questions in the Q&A box. I may invite comments occasionally throughout this presentation. If I do not get to certain questions that you have within the Q&A box, I plan to answer them after the presentation. Alyssa and Great Lakes ATTC will post them for you to view afterward. All right, so quick polling question here. Just want to see who's in the room. Alyssa, can you go ahead and launch the first polling question? All right, so what is your current role right now? Are you in a direct service role with women only? Are you in a direct service role with men and women? Men only? Are you supervisor, administrative support, or other? So help me get an idea of who we have right now. Okay. So right now we have majority or at least half of you in a direct service role with men and women. So thank you so much for being here. We have 13% that work with women only. So I know this will be very valuable for you. And then a decent amount of supervisor and administrative support. Alyssa, thanks for sharing those results. Okay, thanks everyone. Here is the agenda for today. We just did introductions, walk through treatment details, including patterns of use and prior trauma. That will lead to the importance of trauma-informed care. Then we will cover pregnancy and substance use disorder, or SUD, as I'll use that acronym a lot as we're going through. 6, we will examine women-specific treatment and the most popular evidence-based practices for women's treatment. You will have a chance to participate if you'd like to. Here, we're going to do a short activity. Don't worry, it's nothing too intense. We will also walk through common experiences during treatment, focusing more on individuals' experiences. We will finish up with gaps in existing treatment, post-treatment, and success rates. Again, please feel free to use the Q&A box or make comments. I do not pretend to be the expert here, but I have conducted a lot of research, interviews, and data collection on this topic. So glad to have you here and to talk about this today. Here are our learning objectives. Describe the current status of women's treatment, especially compared to treatment for men. Learn typical barriers to and statistics around women's SUD treatment and use. Identify components regarding the emotional and physical experience of women with SUD and trauma-informed care practices to employ for best treatment results. Right. I always love starting my presentations around women's treatment with this quote. I've always remembered it from John Corlett, who was previously the director of Ohio Medicaid and director of a Cleveland-based social service, health, and economic think tank, the Center for Community Solutions. Under John's prior leadership and Emily Campbell's current leadership, they deliver easily accessible statistics and information on women's social issues, especially for those who face systemic inequalities. John told me this many years ago, and it was simple, but it really stuck with me. I think it highlights one of the main reasons it is so important to focus on women's treatment and make sure we get it right. Helping women sustain sobriety helps communities thrive. Whenever we invest in women, the gains are much greater because of the primary role women play in families and with children. I did want to give a disclaimer that when we talk about women in this presentation, we are talking about anyone comfortable in spaces designed for women's experiences. That may mean cisgender women, that may mean gender fluid, that may mean trans women. Also, when we focus on disparities here, we are talking about disparities of women in general. We will touch on some racial disparities and LGBTQIA plus disparities, and there are many, many more, but the main focus will be on disparities that women face with substance use disorder. To kick us off, I wanted to introduce this early, and here are the main reasons why we talk about the importance of women-centered treatment and why it's effective compared to a mixed gender setting. So having focus. Due to the complexities of women and the disease, there are benefits to focusing on specific needs of women affected by substance use disorder. It can be done, but it is not easy to serve a female client who needs much support in a mixed gender setting. It may be even more difficult in smaller facilities with fewer resources. We'll talk more about that in a bit, but just think about if you're serving a female on the poverty scale who has custody of a few of her young children. Her needs are going to be a lot different than a male who doesn't have custody of his kids. So you've got female needing to take care of her children also, because it's a huge concern of hers. And then, someone else who's just focusing maybe on their own recovery and getting in contact with their family later on. Group treatment. So most SUD treatment strongly focuses on group therapy. An old coworker of mine, Pam Boyer, always talks about how women are relational. That's a point for gender-specific groups being effective, especially for women with similar experiences. Women typically keep in touch and talk more with family and friends than men. Participation in gender-specific treatment is often associated with greater satisfaction, enhanced comfort, feelings of safety, and increased continuity of care following discharge among women. Disclaimer here, you're going to hear me talk about people that have been influential in my life and my learning. Many of them are based out of Cleveland, Ohio. I know we're talking to the Great Lakes region, so we have 6+ states here, but I'm hoping that if I say something specific to Ohio, you can maybe do the research in your state personally. Or it may be the same, not sure. All right, trauma. So as many as 80% of women seeking treatment for substance use disorders report a lifetime history of sexual assault, physical assault, or both. Comorbid PTSD rates in this population are up to 59%, with even higher lifetime rates. So 80% of women seeking SUD treatment have a history of sexual or physical assault, or both, and then 59% have PTSD typically. One of the studies that I looked at as I was doing my research includes 115 incarcerated women in gender-specific treatment. For those with prior trauma of sexual or physical abuse, the study showed that gender-specific treatment was effective. For those without previous sexual or physical abuse, the outcomes were not significantly different from the mixed gender group. So that study is obviously very small and a certain subset of people, but we know incarcerated women have a very high rate of trauma. So with that group, it did show that women with sexual or physical abuse did much better in a gender-only, gender-specific setting versus those that did not have it did well in the mixed gender setting. For a trauma healing environment, safety is the most important aspect. Some women are traumatized by a male counterpart, so having all women groups can create the safety aspect. And limited research. So there are a growing number of studies showing gender-specific treatment as effective for individuals with trauma, as we talked about before, and it's most of the population that we treat. Most female-focused treatment studies have significant limitations. So most of the research focuses on white, affluent patients who have obviously a better trajectory than low-income or minority clients due to social determinants of health. If they include people of color, they do not control for cultural differences in groups. One study focuses on incarcerated women, but it is small and the only one of its kind, as we discussed before with the 115 women. Not many studies focus on a large sample of women, so these are typically 60 to 150 participants. The largest studies with thousands or millions of participants separate women from men, but lack any gender-specific components in the curriculum. Some include more people of color, but do not account for culturally competent programming for the various groups. And we also know that most treatment settings base their models on European models of care, which is definitely reflected in the research also. So a lot of limitations there, but wanted to give this high-level overview of why and when women-centered treatment can be effective. All right, women who use drugs. This is getting into kind of the initial patterns of use, both emotional and physical. So on the emotional side, we know there are many emotional reasons for use, but here are the top that I wanted to highlight. So trauma, as we talked about before, I won't go really deep into this. We're going to do some more later. Marital status. So married women who are 18 to 49 years of age have a lower rate of alcohol or illicit drug abuse or dependence than women of any other status. Their rate of SUD is around 4%. And I did want to give a disclaimer here that I could not find a newer projection here. This is a few years old, so just take that with a grain of salt. But at least they reported in 2020, 4%. I'm sure this is a big surprise to you, but history of divorce is positively associated with illicit drug use among women. There is about an 11% SUD among divorced or separated women. Again, it's a few years older, but give or take 11%. There are high rates of SUD among never married single women. So, and these are 2023 statistics, so they are recent, but of women ages 18 to 25, 27% had substance use disorder. I'm going to repeat that again. For the ages of 18 to 25, they are reporting 27% have SUD. These ages are often associated with single and not married. Also, compared to men in this group, they are up to 29%. So I was very astonished at that, but that might be with marijuana legalization and continued access to alcohol and other illicit drugs as people are getting younger. For that group, 14% of women will get treatment here compared to 10% of men that have substance use disorder. Also wanted to note the age group of 12 to 17. They were at 11% substance use disorder. That's women compared to boys at 6%. So again, girls are higher in that 12 to 17 adolescent age range at 11% SUD. Boys are at 6%. Also, girls have a higher rate of treatment. So 21% of girls with SUD are getting treatment compared to 17% of boys. So some really high statistics in our 12 to 25 population right now. Women are affected by family substance use as much as men. And you've seen the 50% chance or likelihood of developing SUD if one parent has a substance use disorder. Yet there can be more shame and guilt associated with use compared to men. Men typically are more likely to admit a substance use disorder versus a prior abuse, and women are the opposite. So women are more likely to admit an abuse versus a substance use disorder. And sexual orientation. Minority LGBTQIA plus women experience exceptionally high rates of substance use. LGBTQIA women experience a much greater risk for depression, suicidal thoughts, and serious psychological distress. Transgender women in particular experience high levels of trauma and violence. The Great Lakes region, the city that I live in Cleveland, Ohio, again, has one of the highest rates of violence towards Black trans women in the US. The YWCA coined it as the epicenter of violence against Black transgender women. So if that's what we're seeing, I'm sure you all in other Midwest states are seeing similar statistics there. On the physical side, so talking about substance related, there are several studies that have relative to men that are showing a small subset of women having a faster course of substance use disorder. Women metabolize alcohol slower than men, causing greater intoxication for females relative to males when the same amount of alcohol is consumed. And that's pretty common. And a lot of people know that. Initiation. So up until this point, initiation of substance use typically begins after an introduction of the substance by a significant relationship, such as a partner or spouse. And that is for women. Also up until this point, women had older ages of initiation compared to men. But with the 2023 drug and alcohol use statistics, as I talked about before, from the National Survey on Drug Use and Health that they publish, and SAMHSA also always shares, there's a higher rate of use in girls from 12 to 17, as we talked about before, compared to boys. So we cannot confidently say at this point that women have older ages of initiation, because we are seeing that women at that 12 to 17 age range, or girls at that age range, have a higher rate of substance use compared to boys. I would think times are changing, popularity of vaping, higher availability of marijuana and alcohol are all factors. All right, physical health side. Some substances can increase the likelihood of infertility and early onset of menopause. There is an increased risk of breast cancer with alcohol use. The Susan G. Komen Foundation reported through 53 studies that for each alcoholic drink consumed daily, The relative risk of breast cancer increased by 7%. So again, for each drink consumed daily, breast cancer risk up 7%. Women who had 2 to 3 alcoholic drinks daily had a 20% higher risk of breast cancer than women who didn't drink. 2 to 3 drinks, 20%. One drink, 7%. Adverse medical, psychiatric, and functional consequences are often more severe in women with SUD. I will not get into those, but I did want to highlight the breast cancer statistic because I do think it's alarming. Even though we know women have higher physical risks associated with alcohol use, men are still 3 times as likely as women to die as a consequence of alcohol abuse. And I would think that's just because of, higher volumes. Among those diagnosed with alcohol use disorder, 36% are women at this point and 62% are men in the United States. Okay, so getting into trauma-informed care. This is a pretty large section. I think it's very important to talk about, especially with women, knowing that trauma is typically happens before the onset of substance use disorder for women, as compared to men. So I do think this is really important. So prior trauma for women. So women with SUD are more likely to have histories of trauma, including sexual or physical abuse or witnessing abuse in childhood. And I have seen for the onset of SUD before it, women as high as 90% have experienced trauma as compared to 40% of men have experienced trauma before the onset of SUD. So I think that's important thinking about treatment where women may not have been actively using when they experience the trauma, but men typically, when they're experiencing their trauma, majority of the time, were using. So just important to think about when we consider treatment. There are various types of trauma, as you all know, and I displayed on the slide here, but I'm going to focus on sexual abuse a bit because it's a lot more prevalent in females than males. Those who have experienced physical or sexual abuse are at a 74% greater risk of developing a substance use disorder, as reported by the National Institute on Drug Abuse and the publication in the Child Abuse Review. The CDC reports that approximately 1 out of 4 women, so 25%, have had at least one sexual abuse experience before the age of 18. According to the US Census Bureau, that we have more than 85 million mothers in the US. So if we think that 25% have had at least one child sexual abuse encounter before they're 18, that leaves us with 21 million mothers around the United States who may be still struggling with prior trauma. Reminder here, it's always better to assume that all your clients have trauma than not, especially if they're women. During the assessment process, it's likely your clients may not remember their trauma, not categorize an event as traumatic, or do not want to disclose something if they don't trust you. As a side note, studies show trauma from previous generations can be passed down on a cellular level, so they really won't remember if their parents or grandparents didn't tell them about prior trauma that they experienced. Trauma impact on women. Number one, it's subjective. So women respond to and are affected by trauma in a variety of ways, based on their histories, circumstances, and other factors. Some women experience traumatic stress symptoms that dissipate over time, while other women are resilient to the effects of trauma and recover from it quickly. 2, impaired brain functioning and development. Trauma can impact brain chemistry and cortisol levels. All of that has a long-term impact on mental and physical health. Clients can often be in survival mode, fight, flight, fight, freeze, and fawn. Fawn is particular for females in trauma. This is people-pleasing, avoiding conflict, and caretaking mode. I know you're probably thinking about different scenarios that you've experienced before. As you can see in this figure, we have 2 pyramids one in the middle, one on the right. And trauma flips the typical brain development. So you'll see the typical brain development in the middle. And if you have developmental trauma, that's the way your development is going to look. So the brain focuses on regulation and survival if you have trauma, versus that high development of cognition and social emotional regulating. Also, I really like this diagram because I don't know if we have anybody colorblind in here, so I'll try to talk through where the colors are, but we do have purple, which is kind of the your top, your front top, and then your back top of your brain that aligns with cognition. And we know this aligns with the neocortex. So that's where your language, abstract thought, imagination, consciousness, reasoning, and rationalizing is. Your midbrain or your limbic system, which aligns with your social and emotional and regulation, which we know also has emotionals, memories, and stores habits and attachments. And then your lizard brain or your brainstem and cerebellum that controls your autopilot and your fight or flight, so survival functioning. Right. Responses to traumatic stress are adaptive. Some women develop psychological disorders, including PTSD and other anxiety and mood disorders, and other women may use alcohol, tobacco, and drugs to cope with the trauma and its symptoms. Others recreate their trauma by engaging in problematic parent-child interactions, including abuse and neglect. Remember, we mentioned the 21 million mothers that are affected by childhood sexual abuse. After a heightened state of arousal, many women report significant sleep difficulties characterized by nightmares, trouble falling asleep, frequent awakenings, problems staying asleep, and apprehension about going to sleep. Among women with a history of sexual assault and PTSD, sleep difficulties are a significant motive to use. And 4, women are twice as likely to develop PTSD than men, along with the physiological and psychological symptoms that often characterize PTSD. The experience of trauma can impact core assumptions and beliefs about self, others, and life in general. One study demonstrated that the severity of the effects of trauma is evident in 2 core beliefs identified by survivors of childhood abuse, also in recovery. I am nothing, so feeling inconsequential, and I am bad or wrong. There is a lot of shame and guilt around the event. Some abusers say, you don't know how good you have it, which is prime manipulation. Or the perpetrator may also have blamed them, like, you asked for this, like a form of punishment. So, in summary, in addition to the abuse or trauma, experiences that lead to feeling inconsequential include being unprotected from danger, telling someone about the abuse and not being believed, being told lies to conceal the abuse, and being unprepared for life transitions. This can lead to shutting down emotionally and isolating. It's essential for each part of the treatment process to be trauma informed. Clients are extra sensitive, and we must always be kinder than necessary and create a safe space for our clients. All right, trauma-informed care reminders. So we have some best practices for staff and organization here. Language, always use person-first language, people who use drugs, or those suffering from substance use disorder. Ensure that every person the client may interact with is kind, calm, welcoming, yet assertive. Admit cultural competency levels, whether they are good or bad, to plan for training and improvement needs. Research and prepare cultural considerations for your specific client base and who you are serving. Verify and validate. Do not make assumptions. Be non-judgmental, empathetic, and encouraging. Avoid power dynamics, so consider meeting in a neutral space for the first encounter, and dress differences. Come to the client's level and meet them where they're at. So, for example, you are going to be perceived a lot differently with jeans and a sweater than you will be with a suit jacket and black pants. Also, meeting in your office could be intimidating for the first time that you're meeting a client. Think about the large desks that you may sit behind, and all of your amazing accomplishments and certificates that you may have posted on the wall, and many books like I do over there. That could be very intimidating for a client and really makes a power dynamic between you and them just at the first encounter. So feel free to kind of think about your space and make sure that it is welcoming and empowering to the client. Always allow clients to give feedback about their care. Love those client satisfaction surveys. Use curriculum containing evidence-based practices for women, especially for trauma and PTSD. We'll talk about a few in a few slides. Talk clients through all processes, especially if conducting a search to enter a residential facility. Otherwise, be careful of space and physical touch. Talk them through everything that you're doing very slowly and ask if it's okay. Obviously, some things are required, but get consent as you can. Provide psychoeducation around SUD, trauma, and mental health. Do not force someone to tell their story early in treatment. A female client may be ready when some coping skills are developed, is emotionally stable, and has a period of abstinence, is interested in doing the work with you, can reach out for help when in danger. Suicidality has been evaluated and taken into account and has no immediate planned changes in their treatment, like discharge, transfer, etc. Women need time to contemplate and pursue personal interests in residential treatment, like music, art, and recreational activities. Sometimes they don't have time to do this outside. So it's really important to focus on all aspects that'll be important in their recovery when they're in treatment. A non-punitive atmosphere where conflict is addressed by negotiation. Setting a positive tone by respecting clients' personal needs. Having snacks, water, and coffee if clients are hungry. I know we all don't do well when we're hungry. And offering a break during a long assessment instead of waiting for the client to ask. Actions are client-centered, client-chosen, and client-permitted. The majority of the staff are women, and male staff are trained in women-centered care, trauma, and domestic violence. And I know some women-only treatment centers talk about, isn't it really important to have an all women female staff? And it can be important to have male staff members. I think especially if some of our female clients haven't had a positive relationship with a male figure, having a positive, healthy relationship with a male counselor can be very beneficial for them. But we need to make sure that those staff members are trained in what they need to be: women-centered care, trauma, and domestic violence. Best organizational practices that we can think about is space is welcoming, and the artwork reflects heroines from many cultures. A connection to women's history and female figures is important in bolstering women's self-efficacy. An organizational structure that allows clients to access and engage with several layers of staff and administrators. Administrators walking around, being visible, talking to clients, does work wonders. Policies and procedures that promote safe and respectful employment and growth opportunities. Encouragement of assertiveness, honesty, and leadership. Providing opportunities for privacy and meditation for clients and staff. Encouraging staff self-care versus self-sacrifice. Available emotional support to help staff avoid client blaming, defensiveness, detachment, secondary traumatic stress reactions, and burnout. And shout out to Great Lakes ATTC, because I saw that they have a tab with a lot of self-care resources for staff available on their website if you want to check that out. Creating a space for healthy interpersonal relationships. Finding meaning in difficulty as you're able to. Training, supervision, debriefing, employee services, staff appreciation, remembering the 4 R's, which is realize, recognize, respond, and resist re-traumatization. We know that triggering is inevitable, but we must resist re-traumatization of the clients. Right, and trauma-informed care principles, things to think about. The question to ask here with our clients is what happened to you versus what is wrong with you. And here are all different aspects to consider for trauma sensitivity, safety, both physical and emotional, trustworthiness and transparency, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender competency. So the book Trauma in the 12 Steps by Dr. Jamie Merrick. I just read this for and added this into this year's presentation. I've done this presentation for a few years. And when I was doing research a few years ago, someone had said, oh, you need to read this book and incorporate it in your presentation. So I finally got around to doing that and incorporating it. It includes valuable accounts of how some of the 12 steps and slogans can be challenging for trauma survivors. Dr. Merrick highlights the importance of remembering that the steps are suggestive and staying flexible when working with trauma survivors. I did want to mention that I do love the 12 steps. I am an Al-Anon member. I am very proud to be from Northeast Ohio, where Dr. Bob lived, and Bill W., and they met in Akron, Ohio in 1935. So disclaimer there, but I think Dr. Merrick makes some really valid points about thinking about what might be difficult for a trauma survivor if they enter the rooms. So here are the 12 steps, and what I did was highlight in green some of the words that may be difficult for trauma survivors. So I'm going to go through and tell you why. Step 1, issue here that a traumatic experience can cause someone to be powerless, which that's why I highlighted powerless. So the word itself can be troubling, even though the intent is over alcohol. The modification suggested in her book is viewing this as a goal rather than a requirement. For steps 2 and 3, reliance on something other than self might be challenging. Turning the power over to something else can be impossible, insulting, or too risky for a trauma survivor. Step 4, the word moral can be an issue for those who grew up in a strict religious environment and were often in internal conflict with the values that were held by their family members. And if the trauma happened to be immoral, or they had to do something to survive that was immoral, they may see this as a reflection of themselves being an immoral person. Step 5, admitting to another human being. Sometimes unresolved trauma and the survivors believe that they are shameful, defective, or crazy makes this step nearly impossible. Also, those chastised for telling secrets may fear punishment for writing things down and sharing. Step 6, the word defects is difficult, and it conflicts with the goal of empowering the trauma survivor. The use of the word defects might bring out shame, regret, and worthlessness. The book suggests using the word or the phrase negative coping skills versus defects. This is done in Workaholics Anonymous. Right. So number 9, made direct amends to such people wherever possible, except when to do so would injure them or others. There may be a lot of crossover between those that they hurt and those that inflicted abuse upon our trauma survivors. They may feel my abusers need to make more amends to me than I need to give them, and that's valid. So for steps 10, 11, and 12, some of the challenges here include the spirituality tie. If the survivors had to do things that were immoral or illegal and against God's will to survive, they may have an issue with these steps. So again, things to consider that you may have to work through with trauma survivors around some of the 12 steps if your treatment program incorporates them, or if you require your clients to go to meetings outside of treatment hours. Some of the slogans: one day at a time. This can be an excellent goal to work towards, but very difficult for a trauma survivor due to what happened a long time ago, feeling very real today. We talked about the limbic brain before. This is where memories are stored. It has no rational sense of time. So for a trauma survivor, those memories can feel very real today than they did in the past. So living one day at a time is quite impossible if they haven't recovered from their trauma. Think, or think the drink through. Triggering can cause the reptilian brain and the limbic brain to take over. So that survival brain and then the limbic brain. And the neocortex, which is our rational thinking, goes offline. So thinking is out of the question for someone who is always in the rational or the reptilian and the limbic brain, operating in survival mode. The best thinking got you here, or stinking thinking. Then also, trauma survivors, their thinking sometimes was necessary to save their lives, which is directly in conflict with this. So kind of some balancing to do here. We are only as sick as our secrets. Trauma survivors may have felt that they needed to keep secrets as a part of survival. Often, an abuser would threaten them if they told anyone what was going on. Take the cotton out of your ears and put it in your mouth. This is probably pretty self-explanatory if you think about sexual abuse, but I'm just going to say it in case it's not as clear. But sexual trauma survivors may have been gagged or had to do things with their mouths. So not a great slogan for a sexual trauma survivor. This also reinforces the don't talk, don't trust, and don't feel that may be taught in emotionally dysfunctional households. Our feelings are not facts. When the limbic brain is in control, the rational thoughts of this feeling shall pass, which comes in the neocortex, may not be accessible. KISS, or keep it simple, stupid. The word stupid is the issue here. Thinking you are stupid keeps you in the shame rut. So again, just some things to think about. I do highly recommend this book. I listened to it on Audible because I have trouble sitting down and actually reading a book. I like to listen. But yeah, highly recommend it. I do know that Stephanie Covington also has a book on the 12 steps and women's recovery. So I haven't checked that out, but might be another great resource if you're interested in this topic. So quickly, risk of non-trauma informed environment. And these are listing the potential impacts on client and potential impacts of staff if you don't have a trauma-informed care base. You can violate some things that you may do that may be violating a trauma-informed care environment, might be violating clients' boundaries, breaking trusts, especially with unclear expectations or not following through. Chaotic treatment environment, rigid rules that are too difficult or do not allow someone to feel safe, or maybe you are not offering enough resources. Here are some questions to consider about those two topics. So what is your success rate in treatment? And are alumni giving feedback that your programming is too strenuous and they can't make it through? Are those not completing treatment reporting barriers that may be accommodated for? So are you not providing all the resources that someone needs to make it through a successful recovery? Lots of routine disruption, labeling intense rage, other feelings about trauma as pathological, minimizing, discrediting, or ignoring the client's feelings or responses, disruption of staff relationships because of shift changes and assignments. In this, I know this is tough because of turnover, inconsistent enforcement of rules. Again, tough with turnover and a lot of staffing changes, obtaining urine specimens in a non-private manner. As you can see, all of these things can devastate both clients and staff. Here are some possible triggers within the first 72 hours in treatment, especially in an inpatient or residential setting. Feeling ignored, lack of privacy, feeling pressured, whispering arguments, being stared at, isolation, smells coming from your cafeteria, loud noises, loud music coming from client rooms, time of year or day, could be depending on a death or traumatic event, body search, touch, frequent room checks, contact with family or children, or no contact with family or children, intake questions, male staff, the trust me from staff members, not having control, guilty for abandoning responsibilities. I know we have a lot going on in the chat box, but I'm not sure if anyone has any others that they know could be possible triggers. Feel free to put those, feel free to put them in the chat. I see that someone, maybe when we were going through the 12 steps, they gave some suggestions. So thanks for those. I didn't see them. I was talking through. Right. So moving on to pregnancy and treatment gaps. So wake up if you've fallen asleep after our 40 minutes or so. We have another polling question. Alyssa, would you be so kind and share it? So according to SAMHSA's 2023 National Survey on Drug Use and Health, what percentage of pregnant women reported alcohol use? So we have 2%, 5%, 8%, or 11%. And we've got 14, 16 answers so far. Keep them coming. I know we have a lot more people than that are with the that are on with us today.
Ashley, while we let people answer the poll question, someone is asking about a link that you referred to. Do you remember? I know you did the ATTC link, but was there another link that you referred to?
Maybe. I don't know if they can get more specific on what it
Yeah.
was then.
Okay. Danny, if you could let us know which,
Yep,
topic she was talking about, we will get that answer for you.
yep. All right. I'm gonna end this poll and then it'll share, right? I have to share results. Okay. So correct answer is 8% of pregnant women report use. Obviously, depending on substance, that goes up and down. So 42%, so most of you did get that right, but 11%, 39 or 39% of you answered 11%, which actually was more accurate a few years ago. So you were spot on with that if it was a few years past. Thank you all for participating in that. I appreciate it. All right. So statistics on use during pregnancy. The rate of pregnant females seeking treatment rose from 2% to 28% between 1992 to 2012. SAMHSA's 2023 National Survey on Drug Use and Health reported past month use. These are all between 4.9% to 8.4% with use. And 8.4% of pregnant individuals reported alcohol use, as we talked about in the survey. This was decreased from 11% in 2021. 5% of pregnant women reported past tobacco use. 4.9% of pregnant women reported past illicit drug, marijuana, and opioid use. So they did combine all of those for the statistics this year. So 4.9% for illicit drug, marijuana, and opioid use. I did want to point out that also breaks it down by age group in pregnancy. In 2022, 15.4% of pregnant people that were ages 18 to 25 reported marijuana use. So in 2022, 15.4% of pregnant women ages 18 to 25 were using marijuana. This went down to 8.2% in 2023, so almost decreased by half in just 1 year. I don't know if that was 2022, pandemic was still happening, but we had a significant decrease in 2023. Here are some of the effects on SUD in pregnancy by substance. Alcohol can cause miscarriage, stillbirth, and a range of lifelong physical, behavioral, and intellectual disabilities, including fetal alcohol spectrum disorders, FASD. Nicotine can cause damage to a developing baby's brain and lungs. Opioids, this can cause preterm birth, stillbirth, maternal mortality, and neonatal abstinence syndrome, NAS. Marijuana, the available research shows that marijuana can cause cognitive development issues with increased risk of attention, social and behavioral problems, neuropsychiatric disorders, low birth weight, preterm birth, and neonatal unit placement. NAS, or neonatal abstinence syndrome that we talked about. In Ohio, we saw 1,900 NAS cases in 2018. This did decrease to 1,300 in 2022. So that was almost a 19% decrease from 2018 to 2022. So 1,900 to 1,300 cases. In treatment, using methadone and buprenorphine can lead to neonatal abstinence syndrome in a newborn, but neonatal abstinence syndrome is treatable, and infants can make a full recovery. With buprenorphine, only 1 in 10 babies go through withdrawal symptoms. We're going to talk a little bit more about comparing the buprenorphine and methadone during pregnancy too. Fetal alcohol spectrum disorders. So the FASD United Policy and Training Center estimates that Ohio's 135,000 annual births, that around 6,700 have FASD. So this is about a 5% rate. This is much higher than those diagnosed with FASD. It's challenging to actually diagnose fetal alcohol syndrome disorder because there is no medical test. A doctor diagnoses it based off of signs, symptoms, and mom's admission to using alcohol during pregnancy. The extent and severity of potential risk to mom and baby depend on the drug and frequency of use. Some common effects include miscarriages, preterm birth, stillbirths, maternal mortality, and dangerously high blood pressure. Fetal alcohol syndrome disorders is incurable. Some effects, such as cognitive challenges, can affect the whole child's life. So comparing fetal alcohol syndrome with neonatal abstinence syndrome, FASD is incurable and NAS is curable. So some common barriers to treatment for pregnant women include transportation, for example, when going to receive daily methadone doses, care for existing children when attending all aspects of treatment. So childcare there is really important for their current children that they have custody of. Lack of resources, such as additional fetal scans, mental health services, trauma-focused treatment, and the need to feel safe. In some cases, needed services are fragmented and difficult to access. There's high risk of food and housing insecurity among pregnant women or pregnant people. The postpartum period, the first 6 weeks after childbirth, causes increased stress and presents high relapse potential. Some women fail to seek treatment for SUD for fear that their unborn child and other children will go to foster care and they'll have an open DCFS case. So I wanted to talk about the role of the justice system in SUD treatment and potential legal implications with pregnancy and SUD, since this is a large concern for both the treatment side and clients. In many states right now, pregnancy criminalization exists in various forms. And the definition of pregnancy criminalization is a crime that you would be arrested for if you're pregnant, but not otherwise. So, for example, substance use and abortion would be two instances of pregnancy criminalization. 90% of these cases were for substance use, though, and 85% of these cases were affecting those in poverty. This map that I have on the slide shows the states where pregnant persons can be charged with child abuse and neglect for using during pregnancy or the infant testing positive for substances at birth. I know in Ohio, our Supreme Court ruled in 1992 that use during pregnancy isn't a crime, but if the child tests positive at birth, it is reportable to DCFS or the Department of Children and Family Services. Not sure what it is like in your state, but it's always important to do the research and see what your state's regulations are so you can be educated and your client can be educated. You may remember the days when hospitals would not drug test women because they thought they would have to report them for child endangerment. So combining fear of current children being placed in foster care and child endangerment charge with stigma, fear, and shame, it is not easy to get help when you are pregnant with substance use disorder. So treatment of SUD in pregnancy, the American College of Obstetricians and Gynecology, ACOG, and the American Society of Addiction Medicine, ASAM, recommend using MAT to treat opioid abuse in pregnancy over medically supervised withdrawal. They advocate for continued use of MAT in the postpartum period. These two organizations found a significantly high chance of relapse when a pregnant woman goes off an MAT. Just a disclaimer here, we know that medication alone is not sufficient for the treatment of substance use disorder in pregnancy or anytime. If you're looking at a harm reduction approach, potentially. But combining medicine and women-specific psychotherapy is the most effective approach to treating substance use disorder in pregnancy. Something to remember here, buprenorphine can be sent home for daily or everyday doses, resulting in isolation. But with methadone, you must come in daily. So there is monitoring there. So something to consider for your clients. A study released in December 2022, studying over 15,000 women who used buprenorphine or methadone, found that 50% of the buprenorphine babies had neonatal abstinence syndrome, compared to 69% of methadone babies. So 50% for buprenorphine, and 69% for methadone babies, occurrence of neonatal abstinence syndrome. Buprenorphine also leads to a 10 to 20% increase in birth weight. So as we know, birth weight is directly correlated with positive infant outcomes. Overall, buprenorphine is tied to better birth outcomes for the child. So when considering both of them, we know that, methadone may be a better solution for someone who may be at danger if they continue to isolate. So coming in every day for that monitoring may be important, or buprenorphine if that isn't a concern, because it does show better child outcomes. Anesthesia that is recommended for labor and SUD patients is Nurexiol. And the postpartum pain management uses a multimodal approach that starts with non-opioid pain relief. I talked to Dr. Greg Boehm in Cleveland, Ohio, and he said that someone who's on buprenorphine, he recommended to stay on it. It's 40 times more powerful than morphine, and taking someone off buprenorphine during surgery can harm them and put them at risk of overdose. Rooming in with mom in infancy and skin-to-skin contact increases the child's survival by up to 80%, so that's always important. There continues to be a significant stigma around women who use during pregnancy. Healthcare providers, especially maternity wards and NICUs, need to have a much more understanding of the disease and compassion for the individual. We still have much work to do to improve. I know there's a lot of stigma around use that is dissipating, but stigma always continues to remain high for individuals who are pregnant who have substance use disorder. All right, treatment and gaps. So we are right at the halfway point, and I have a kind of activity that I'd like you all to engage in if you can, if you know anything about these evidence-based practices. So hold on one second. I'm gonna move this over. Stop and present. Okay, so on this screen, I have left-hand side and far right-hand side, the 8 evidence-based practices for women and trauma or PTSD that are recommended. And what I have in the middle are all the definitions around them. So this is basically a matching exercise. So what I'm going to do is read from 1 to 8, all the definitions. And then when I'm done, I'm going to come back and read through 1 and see if anybody knows what it is or what matches there. So if you don't know, no problem. I have the answers, obviously. So I will give them after a few seconds of waiting for some responses in the chat. Okay, so I'll read through them first, and then second round, we'll do some answers. All right, 1, a comprehensive evidence-based program specifically designed to support women who have experienced trauma by Dr. Stephanie Covington. The curriculum is gender responsive and trauma informed, addressing the unique psychological, emotional, and physiological effects of trauma on women, including the prevalent links between trauma and addiction. 2, a comprehensive treatment program designed for women struggling with addiction, particularly with the criminal justice system, created by Stephanie Covington. It integrates trauma-informed care and addresses the specific needs of women, including histories of abuse and trauma. The program consists of 20 sessions that combine cognitive behavioral therapy, mindfulness, and trauma-sensitive practices. It emphasizes healing the mind-body connection and is offered with a facilitator's guide and participant materials available in multiple languages. 3, an evidence-based practice, which is a therapeutic model designed to address both trauma and substance use disorders simultaneously. It focuses on coping skills, fostering safety in behavior and thinking, and avoiding re-traumatization. This flexible, present-focused approach can be used in various settings and does not require clients to relive traumatic experiences. It aims to improve safe coping skills and overall stability by combining cognitive behavioral therapy, psychoeducation, and empowerment strategies. 4, integrates cognitive behavioral techniques targeting both PTSD and SUD. The therapy includes relapse prevention, coping skills, training, psychoeducation, stress coping skills, and exposure therapy. It is designed for a diverse population and aims to reduce PTSD severity. 5, a trauma-informed intervention designed to integrate addiction and trauma. Dusty Miller developed it, and it is a 12-session format with group work and individual therapy. The core components focus on blending peer support, psychoeducation, interpersonal skills training, creative expression, spirituality, and community action. This model has been applied in various settings, including prisons, recovery centers, and community programs for trauma survivors. 6, a trauma-informed intervention designed to help individuals learn skills to regulate emotions, cope with stress, and reduce symptoms related to PTSD and trauma exposure. The program is structured to support both group and individual therapy formats, targeting emotional regulation, self-efficacy, and active coping. The approach focuses on helping individuals understand how trauma affects the brain, emotions, and behaviors. The key is to empower participants to recognize their triggers and develop strategies to manage their emotional responses without necessarily diving into traumatic memories. This is especially valuable for individuals who may not be ready to process significant memories but still need tools to manage their trauma-related symptoms. 7, a comprehensive group-based intervention designed to support women who have experienced trauma, particularly those with histories of sexual and physical abuse. Developed by the Community Connections in Washington, D.C., the model uses cognitive restructuring, psychoeducation, and skills training to help participants manage the mental health impacts of trauma, such as PTSD, depression, as well as SUD. Its primary goals with 24 to 29 sessions are to enhance trauma recovery skills, build social support, and foster empowerment. It is highly flexible, allowing it to be adapted to different populations and contexts. And finally, 8, a practical theory survivors of childhood trauma and abuse who are also chemically dependent. The model embraces the disease model of addiction and treatment for the addicted survivor. The model organized recovery into 5 stages: crisis, like maybe we had a connection issue, but I'll keep going. The model organized recovery into 5 stages: crisis, skills building, education, integration, and maintenance. Each stage presents a unique set of challenges, and the authors clearly describe goals, indicators, and treatment strategies appropriate for each stage. Okay, I see some of you have already noted in the chat. And oh, wow, good job, guys. Trying to find. So back to 1. I think, let's see if anyone, I know we have some answers there. So someone said integration model atrium as 8. Let's do 1. Yep, you got it. Helping, let's see. Women recover is actually number 2, Mackenzie, but good call. So I'm going to put that one there. It is Stephanie Covington. So that may make it easier if you know Stephanie Covington's other work. This is an older one for number 1, Beyond Trauma. Got it. All right, so number 3 here. Anyone know what number 3 is? I've seen this used a lot in criminal justice system settings. Give another couple seconds. Atrium is a good guess. That one isn't till later. Trem is a good guess, Danny. 1 isn't till later either. Beyond Trauma. 1. Yep, you got it. Verona. Target is another good guess. That's later on. So this one, number 3, is seeking safety. And I do know that someone had mentioned that before. So I'm going to put this here. All right, number 4. This one was mentioned earlier. Number 4. And somehow I have this. Here we go. Yep, Sheila's got it. SDPT, and sorry about this icon here. So SDPT, and you guys will all get this too. I'll make sure this is included in the handout so you have this as a guide. So we've got number 5. And I'm newer with the software, so please forgive me since this is all around. Number 5, any guesses here? Dusty Miller's. This was mentioned before. Has a nice acronym. All right, this one is the Atrium model. So 12-session format. Number 6. Again, this one was mentioned before too. Any guesses? Tram, thank you. So what slide number is this? It is, we are not on this slide if you're using it, so it's going to be the evidence-based practices model, but it'll list the different evidence-based practices, the 8 of them that we're looking at, and then this is shared differently. And number 6 is, yeah, target. You've got it, Demetria. Thank you. I need to bring it to the front. All right, well, it's there and it'll be there when you all get sent this. Can you tell that I'm new at this? Hold on. I'm gonna slide down. All right, 7. Any guesses for that one? This one is mentioned a few times. Developed by a group in Washington, D.C. 24 to 25 sessions. We only have really 2 left. TREM or treating addicted survivors of trauma. Nice job. It is TREM. And then 8. Obviously, we're left to treating addicted survivors of trauma. All right. Thank you all for playing along. Hopefully you got to stretch a little bit while we were going through that. And I'll have a list that posts that with the slides and questions at the end of this week. So you will have access to it. All right, so from current slide. Common barriers to treatment. So looking at culture and stigma. So stigma, we did see dissipation of stigma during the pandemic. In June 2021, 40% of US adults reported struggling with mental health or substance use disorder. So that's huge in comparison to what we've seen in the past. We still have a lot of work to do too, especially with pregnant women, as we talked about before. Culture. Previously in the US, there was significant variation across cultures. So men were more likely to have access to substances relative to women. Again, previously, because we're seeing statistics and age use or use at young age be similar or higher in women. Around the world, though, we are still seeing disparities across access between men and women, causing differences in substance use disorder statistics. For the US, the prevalence of SUD in men and women is almost the same, showing that this isn't true for us anymore. SAMHSA in 2023 shows that the US is still the world's top for female substance use disorder. Our culture is also conducive to putting women against each other, living competitively versus lifting each other up. We see this on TV, social media, and many other places. Women always need to help women. And women and men both judge women harshly. This is internalized sexism if it's coming from another female. Men and women are socialized differently in the United States. Family obligations, number 2. Previously, women had older ages of initiation than men due to more parental and imposed constraints, monitoring, and more home responsibility. As a general rule, women who grew up in families taking on adult responsibilities as a child, including household duties, parenting of younger children, and emotional support of parents, are more likely to initiate drug and alcohol use. When the parenting role is culturally acceptable over 18 and with a biological child or other, when women are typically the primary caregivers for children and older adults or older parents, they put their recovery and self-care second to their children or their significant others. Also, if the family doesn't heal, they may have the same expectations from the person returning home post-treatment, which may or may not be conducive to sobriety. There was a point brought up that women are more likely to leave treatment compared to men or abscond from treatment. For my interviews and research, it seems the biggest reason for leaving treatment is children. especially in a residential or inpatient setting. I'm curious if anyone has any other thoughts on why women tend to leave treatment very early on in a treatment setting. Kind of look at the chat to see what we've got. All right, not that I'll keep moving on. 3, lack of effective treatment navigation. Men are more likely to receive specialized SUD treatment, self-help groups, specialized outpatient treatment for opioids. In contrast, women with SUDs are more likely to seek treatment in a mental health facility setting. Also, 4, complex physical health concerns are treated before substance use disorder. The healthcare system and culture still prioritize physical health over SUD and mental health, even though we are making a lot of strides with urgent cares and that are for behavioral health. Some older physicians do not believe in SUD treatment and effectiveness or know how to navigate system resources. Many of us don't know how to navigate system resources, so they're not alone. And again, we're making strides with peer support in ERs, behavioral health urgent care centers, harm reduction sites, but we have a lot more work to do to address the needs that people have to get the right placement. All right, common gaps in treatment. So, especially for women, there's always a need for wraparound services due to their multiple complex barriers and those that are associated with them. Childcare for women that are in custody of their children is a must, or trying to figure out care for their children while they're in treatment, whether that's childcare on site or whether it's having a partner where the child can go while someone is recovering that they know is safe. Case management for families, case management for the client and their families, transportation needs, whether that's using Uber Health, Lyft, vans, bus routes, or bus tickets if you have an accessible city. Finances. So there are higher rates of financial abuse in women. Women still make a lot less than men make on average, so 88 cents to a man's dollar. They have to financially support their children, their family members often. So that money has to get stretched. Integrated healthcare to be able to treat medical and mental health and substance use disorders. Trauma-informed care and training for male counselors to make sure triggering is limited. And we talk about that the length of support for women needs to be extended for her and her family. So someone that's very active in Ohio in women's recovery housing, who's also a clinician, her name's Erin Helms, and she always talks about a 5-year treatment and recovery plan. So really extending what we think about as a traditional treatment model in the United States. The family disease and expectations and pressure from family members only change post-treatment if the family gets help and support that they need. It's important to continue to offer and push family education groups. I have been to some family groups. I know, at least in Northeast Ohio, Jim Joyner offers a virtual family group called MeWe, or Al-Anon groups. And I know that Dennis Daly out of the University of Pittsburgh also speaks and does a lot of work around family systems, but very important to obviously educate the family so they can be supportive of someone's recovery. We need better collaborations to promote integrated wraparound services for the complex needs of women. We need to be able to offer behavioral health care on site or refer or partner with social service agencies for support. We have a huge job. We are offering healthcare to our patients, running social service agencies simultaneously. Last year, I heard someone speak, and they were talking about imagining counselors and social workers that are in the behavioral health field as recognized in the STEM field. And I love this notion, and I think it comes with a shifting of being able to focus on counseling, evidence-based practices, and focusing on that versus all of the other needs that our clients have. around housing, around food, around medical, around education, financial, you name it. We do it all. And it's difficult to do it all without the right support. So, whether that's collaborations or gaining resources, that we can do it all. Relative to men, women in SUD treatment consistently report more severe issues with employment, social, family, medical, and psychiatric functioning, as well as the poor overall quality of life. Several studies do indicate more significant legal problems compared to men. All right, getting into treatment experiences. So emotional experience during treatment. Women typically have a self-reported and often more observable higher stress level appearing in treatment. Also, we know there are many barriers for women in treatment, as we've discussed, contributing to difficulty staying in treatment. For all the reasons discussed, many women appear more hostile to others around them in treatment settings. In the first year of recovery, women experience a greater initial decline in happiness and self-esteem than men. I'm going to say that again. In the first year of recovery, women experience a greater initial decline in happiness and self-esteem than men. Generally, women tend to be happiest in the early years of their lives and the most unhappy between the ages of 40 and 50. So you think about it as a U-shaped curve. So women are really happy early on in their life, 40 to 50. And you think about body changes, menopause, 40 to 50. And then as women get older, they tend to be happier. There's a lot of anxiety and depression at that bottom of the U-shaped curve. For men, age 50 is when they tend to be unhappiest, so a little bit later in life. Due to a woman's tendency to be relationship-driven while experiencing many new and frightening emotions during early recovery, women have an increased chance of pregnancy during treatment. They may be seeking validation from a male counterpart while in early recovery and processing many more emotions than they had while using. This can be a coping mechanism and a way to self-soothe from probation and treatment, those things that they can't control. Additionally, if they are not changing their people, places, and things, they may continue to use without the use of contraceptives to please a partner. Hence, it is very, very important to have sexual health education and testing in an outpatient treatment setting because you are not with them all the time. And in residential and inpatient because they may assume habits once they leave. All right, going over to the physical experience during treatment. Body image and women in recovery. Whew. Many women are uncomfortable with themselves anyways. Then you add weight gain in treatment. Women on increased medications and treatment that can cause weight gain can be difficult for someone to accept. Also, we know some addiction habits can transfer right over to a sugar consumption habit. So let's look at smoking for a minute and how this ties with success rates. Women have a harder time quitting smoking than men do. Women metabolize nicotine, as you know, is the active ingredient in tobacco and cigarettes, faster than men. Differences in metabolism may help explain why nicotine replacement therapies like patches and gum work better for men than women. Men appear to be more sensitive to nicotine's effects relative to substance use disorder. Although men are more sensitive than women to nicotine's addiction-related effects, women may be more susceptible than men to non-nicotine factors such as sensory and social stimuli associated with smoking, like a greater sensitivity to visual and olfactory or smell cues, and a greater concern about weight gain while quitting. Women have different responses to substances, specifically related to gynecology. Women also have higher risks of the effects of relapse. Deaths from prescription opioid overdoses among women have increased by 400% since 1999, compared with men at 265%. Men in general are still more likely to die and experience an overdose compared to women, even though the women rate female rates have increased. All right, getting to post-treatment and success rates. Gender or sex is not a significant predictor of treatment outcomes or retention for all substances other than nicotine. Where some studies show worse outcomes for women relative to men, evidence for gender differences in response to MAT is accumulating. Studies show women are less likely to complete detox or detoxification or withdrawal management. Some research shows women have greater increases than men in employment, recovery-oriented social support systems, and participation in self-help groups post-treatment. A study found that women have a greater reduction in levels of distress after treatment, although their overall levels of distress appear to remain consistently higher than those of their male counterparts. This always cracks me up because I think it's, you think about a woman comes into treatment at this high level of distress, male average distress level is here. They're both decreasing while you're going through treatment, and then females decrease just a little bit more, but overall, still much higher. All right, so we're getting close to the end here, and best practices and treatment reminders here. So using trauma-informed care always is important. Treating both mental health and SUD, setting clients up for long-term support, keeping barriers to effective treatment in mind, keeping male versus female differences in mind, as we talked about today, knowing the recommended evidence-based practices for treatment, which we'll get you that PDF so you have it as a quick guide, because I know we went through that exercise pretty quickly. And finally, I wanted to thank you all so much for paying attention. I know this is a long training. There's a lot of information that I went through. Thank you so much, Great Lakes ATTC, for having me back this year to go through this again. I think it was great to kind of break this up into two parts. We covered the history last week, which you can find on the Great Lakes ATTC website. They should have it posted in video form. Some great history there, founding of AA, and then some of the key players in women's treatment the years after that. And then today, kind of the overview on women's use and treatment, so a two-part series. And Alyssa, I don't know if we had any questions in the chat.
Yeah, we did have one question in the Q&A come through. It says, I know you said research is limited, but has there been any cost-benefit analysis of incorporating TIC and wraparound in treatment for women? I feel like providers are so pressed to get people in and out of treatment for many reasons. And while great, this seems like it takes additional time our providers may be hesitant to give.
Thank you for that question. While I was looking through things, I did not see anything, but that doesn't mean it does not exist. I'm happy to look some things up and see if I can find anything specifically on that topic, but great question and totally agree.
That is the only question we have right now in the Q&A. If anyone has any other questions, please feel free to put them in the Q&A section. We'd be happy to answer those for you.
And I do have my information that's up on the slide right now being shared. If you think of something afterward or you want to share anything with me, any feedback personally, feel free to send it to my email. I'm always looking for feedback. I do this presentation a few times a year, so always looking for updates to it as we have more relevant information to share on women's treatment.
While people are taking some time to think of any additional questions they might have, I'll use this time to remind you all to please take that post-event survey. I did put that in the chat. Please make sure you take that. Your feedback is greatly, greatly appreciated. We do take a look at that and adjust as needed. It does go back to our funders. So as long as you fill that out, we can continue to provide free trainings to you all. As long as you attended the full session today, I will be sending out a certificate with 2 NADAC CEs. As Ashley said, the recording and PowerPoint will be made available at the end of the day today. I did put the link to last week's 30-minute session if you would like to review that. And then the link for today's session, once we close today, I will start processing that recording. We are having our next session is taking place on December 19th. Registration is coming very soon, so please watch your emails and we hope to see you on that next session. Otherwise, Ashley, there's so much thanks and praise in the chat saying how wonderful this information was. So I we hope to continue to work with you. I don't see any other questions coming in the chat or the Q&A. Oh, yep, the date is on December 19th. So it's going to be a quick 30-minute session from 10 to 10:30 or 10:30 to 11. I'm sorry, 10:30 to 11 Central Time. So it'd be 11:30 to noon Eastern. Awesome. Well, we hope to see you all on our next session and continue working with you, Ashley. It's been wonderful. Everyone just watch your emails for the certificates and the recording link. We hope everyone has a great day. Thank you.
Thanks, Alyssa. Thanks, everyone.